Good morning, everyone. I'm Karthik Guja, Associate Director for the Endovascular Program at Mount Sinai, New York. We welcome you today for the monthly peripheral live case webcast. I have with me Dr. Sadar Farhan. He's our Associate Professor here in the Icahn School of Medicine. We welcome you for this monthly, very exciting live case. Before we go further, the next live case is going to be on January 27th. January 27th. So we look forward to seeing you in the new year after this case. Dr. Krishnan and his team, Dr. Kapoor, Dr. Krishnan, their team, they're waiting for an exciting case. The previous live cases have been archived in our www.peripheralliveinterventions.org, or you can go to the website, look forward for our previous live cases. If you have any questions, we are looking forward to it. And without any further delay, with a bright morning here, we are going to the cath lab. PK, good morning. Vishal, good morning.
Good morning, Karthik. It's a pleasure to welcome all of you here on the last, as Dr. Sharma said this morning, the last live case of 2020, which we're very proud of, that we're able to close the year. It's been a very difficult year for all of us, but we have an incredibly, I'd say, how can you say, educational case for you. First of all, I want to introduce one of our guest operators and a very dear friend of ours, Dr. Ajit Rao, who's here. He's the assistant professor of vascular surgery and at the Department of Surgery here at Sinai, and he's here to help us in our collaboratory efforts here at Sinai to really do what's right for the patient and best for the patient. And this case is really an example of where you really need multidisciplinary approach to this. So this is Dr. Rao to the right. Next to me, of course, is Dr. Kapoor, who all of you know really well from our monthly webcast. Ray Lascano to the back. Sriya Avadani, our outstanding endovascular fellow, is here as well. Elizabeth Holton, our nurse. Damien Cabrera. I'd like to thank the Gore team for getting up early in the morning and coming here and helping us with this case. So without further ado, I'm going to go to Sriya, and then we'll talk a little bit about this case. Sriya?
Mm-hmm. Good morning, everyone. I'm going to present the case. You're just going to go next. Okay.
Sorry about a little technical delay. There we go. Okay. We're up now.
So our patient here is a 42-year-old male, history of hypertension, type 2 diabetes, and hyperlipidemia, who presented to the office with lifestyle-limiting claudication with minimal exertion. He was able to walk 1-2 blocks with pain in his thighs and hips and buttocks. He underwent non-invasive studies, which I'll go over in just a second, for evaluation of PAD. These are his medical history, medications. He is a current smoker, had been smoking for about 15 years. His labs. He underwent ABIs, as you can see on the right side, pretty much in the normal range, but his TBI on the left side was markedly reduced with PVR waveforms that were blunted and widened. So he underwent an arterial duplex that was suggestive of a proximal occlusion before the common femoral artery. He had monophasic waveforms from the essentially from the iliacs down with reduced velocities and calcified vessels. So he did undergo an aortogram at an outside hospital. This was pre-COVID pandemic. Was found to have an Aorto-Iliac disease and occluded osteal-iliacs on both sides. He was kind of lost to follow-up over the past few months, had been exercising, still symptomatic. He was on optimal medical therapy at this point. So he had presented to us with progressive symptoms. We had gotten a CAT scan given the anatomy for pre-procedure planning. We did get an aortic diameter of about 23 millimeters at the level of the celiac artery, and both his iliacs were above 10 centimeters distal to the reconstitution. This is a 3D reconstructed image. As you can see, there's also distal aortic disease with occlusion of both the iliacs, longer on the left side compared to the right. And so
yeah, why don't we
we'll just go over the case.
Has made a nice presentation in terms of the collateral circulation and also approach to these disease, which I think was great because we have Dr. Rao who can educate us on as cardiologists and radiologists on how this is going to work. So Ajit, a couple of questions. So here you have a guy as a claudicant, and also Vishal, I should actually ask, both of you, in terms of this kind of lesion, you have an Aorto-Iliac disease. How often do you get axial imaging prior to these kind of patients? And what is the logic of getting axial imaging in these patients? Ajit?
Thanks again for having me here this morning. It's a great question. So for patients that have aorto-iliac disease, I tend to get a CTA. I always start out with ABIs for any patient with PVD, but for patients with aorto-iliac disease, I think a CTA can really add some value because I think the number one thing is you can look at where you're going to access. You can look at sizing, which is really important in this area, and it can really give you some good preoperative planning on what will be the best option for the patient.
So when you do the axial imaging, I think for the cardiologist, what are specifics of what you're looking at? I mean, I understand, I think we all get the sizing part of it, the length of the occlusion part of it, probably the distal runoff part of it. Is there anything anatomic also beyond that? Calcification, we get it. Mm-hmm. But what about the inferior mesenteric, the superior mesenteric, and renal, so on and so forth?
Right. So, so that's definitely something that I look at with the CAT scan. Because these patients can often have, some sort of chronic mesenteric ischemia. Most of the time, covering the IMA is okay because you have enough collaterals through the SMA and celiac. But I think, the last case we did for similar reason, that patient actually had a diseased SMA, and so we preserved the IMA for that very reason. So I think that's one thing to look at because if you're going to place a covered stent, you don't want to cover the IMA if it's large and robust and perhaps feeding collaterals. So in addition to the SMA and celiac, then you also want to look at the hypogastrics because that's another source of collateral perfusion to the gut and the mesentery.
So Vishal, you want to comment on what your thoughts are?
No, I think I agree with Ajit. I mean, the whole idea of how the anatomy looks, most of the time these patients, even though they have atherosclerotic disease, there might be a component of aneurysm happening with it. So you just have to figure out what's your definite treatment strategy. Are we doing a whole covered stent, a graft, or with the extra limb? So assessing all these atherosclerotic and the anatomical abdominal aortic presentation can change your plan. You can see from the angio here, like Shreya said, initially there was patency. We repeated the CTA in a few months, and now it's all gone. So that gives us how we have to strategize and use our definitive strategy.
So Karthik and Sardar, just a question for you because I know I've got my thoughts and I'll share them. In terms of planning for these cases, you had the CTA that you showed so well. Let's talk a little bit about access points and what your logic would be to get some access prior to starting.
I mean, with regards to access in such a case where we have an aorto-occlusive disease with bilateral iliacs, the bilateral CFA access would be the first way to go, especially in this case where we have nice patent CFAs with almost no calcification, meaning that we can do a bilateral retrograde approach. Of course, since we are talking about an bilateral occlusion of the iliacs, we need an antegrade flow, so probably a left radial access or a right radial access might be an assistive approach to visualize the lesion better and do a roadmap guided access for the large bore access. So I think this is the best way to approach this.
So Karthik, in terms of treatment options, I think he covered all that with access. In terms of treatment options, what do you think are your options on these kind of patients?
I mean, there are only two options, right? Either we do it endovascularly or you do surgical. Surgical is, if I'm assuming, you want to preserve the IMA unless you put a limb, and there is no way to put a limb, then you have to go for a aorto-bifem, which is a pretty major morbid surgery. If I'm not wrong, Ajit can add to that. If the patient has underlying cardiovascular conditions. But if you're going for a percutaneous procedure, again, we have to go for bifurcation aortic stenting. The question is, how do you want to do it? Again, depends on the anatomy, as Ajit and Vishal went over very clearly, of what you want to preserve, what you want to bifurcate, what you want to stent. Do you want to put a limb or not? And how big the aortic, what is the discrepancy between the aorta and the iliacs? That also makes a difference. So, I mean, again, groin access, putting a covered stent, putting a aortic stent and then bifurcating into the iliacs, which is the most common strategy, what we would suggest, and probably the most easiest for the patient as well as for the interventionalist.
So, that's great. Now I'm going to turn to Shreya because she did the CAT scan. Shreya, why don't you give us some measurements? I know you went over them, but repeat them if you haven't, in terms of, what is the distal aorta and the iliacs, what Karthik was asking for.
Mm-hmm.
And Ajit, after that, maybe we can go over a little bit of goals of what we're trying to achieve here, because I think a lot of times we lose sight of the goals of what we're trying to achieve. But go ahead, Shreya.
So here we have a reference aortic diameter at the celiac, or at the level of the celiac artery, pretty normal with not a lot of disease, measuring around 23 millimeters. And then we also measured it further down at the level of the bifurcation. And I think we got about 16 to 18 right at the bifurcation. And we also measured the two iliacs, even though we did get bigger measurements than this, but they were above 10 millimeters on both sides.
11, yeah, they were both around 11. Mm-hmm. So I think that's excellent. And also, the runoffs, right? Because we have the CT runoffs prior to, which shows no obstruction. Or did it show obstruction? I don't remember.
No obstruction below, and also widely patent IMA, SMA, and celiac.
Okay, so now you've got that. Now, with all that information, our goals are obviously as a claudicant. So for me, as an endovascular person, and all three of us here, I think that one of the things would be, obviously, we'd like to give them a durable therapy. So, can you comment on your approach in terms of how you're going to decide that, and why we decided on what we decided to do?
Sure, definitely. So when I approach claudicants, I kind of break it down into three kind of treatment groups, either conservative, endovascular, and open surgery. So, conservative being celestazole and exercise, endovascular, which we're going to talk about in a second, and then open surgery. I think the treatments we have for endovascular are getting better and better and more durable, and certainly the one that we're planning on doing today, I think, has really, high patency and long durability for the patient, which is important because in this patient, he's young, he's healthy, he's going to be walking for years and years. So certainly think about durability for surgery. One of the best operations we have is aorto-bifemoral bypass.
Yep.
It's probably the best bypass we have. That being said, it's a major surgery. It involves an open abdominal procedure. Patients are in the hospital.
And Shreya has some data on that. So,
yeah.
Yep.
For a couple of days. So it's not always the best fit, and a lot of patients may not want that. And I think especially as we're shifting to endovascular first approach for PVD, certainly trying iliac stents and doing the CRAB technique, which has a great durability too, is another
CRAB,
option.
I know the cardiologists are starting to do CRAB, as you know, and the question is, obviously that's a kind of a modification of what we've done in the coronaries, what we call as the trouser SKS kind of bifurcation stent. So the issue here is that in this situation, we both have discussed, Shreya was involved and so was Vishal. Why did we feel that this may be better versus doing kissing iliac stents?
Yeah. So I think this is a great case because there's truthfully multiple ways of
so
approaching it.
Let me go to the aortogram as you look at it. So you see that the left brachial was occluded, and this is from a gunshot wound, and then you can see here we have right radial access, and here's our angio, and I'm just going to let it play and let Ajit talk about our decision process.
Yeah. So when someone has bilateral iliac occlusions in the common iliac arteries, the first thing I kind of think of, which is probably the most common, is doing kissing iliac stents. I think the difference we have here, and one of the important things to consider, is this occlusion goes well into the aorta, at least I think about 3 centimeters or so into the aorta. So putting in long kissing iliac stents all the way up to the level of the IMA or close to it may not be the most durable approach. So I think in this case, and we discussed it extensively, putting in potentially an aortic cuff into the distal aorta where the occlusion is, and then doing kissing iliac stents may be a more durable and better approach.
Right, and I think, Vishal, maybe you can comment on, we've done a CRAB using a VBX and 2 other VBXs. Why did we choose to do a distal aortic cuff here?
I think like Ajit was talking about, the sizing part of it, to attain the maximal sizing. Here, if you look, the distal is 1.9. So the idea is to try to give a good distal aortic sizing.
And the largest VBX is only
like
16. Right?
Exactly. So it can go up to 16. So if you want a good apposition and good patency, like we talked about, we have to do a real reconstruction, and that's where the cuffs, which come in bigger sizes, would give us more patency and expansion of the distal aorta, and then we can reconstruct our iliac. So
right. So our ACT now is, Liz is checking it again. It was a little low. We're on heparin. So we're going to go ahead. We're going to cross out. For full disclosure, we tried to do a pre-close before, and the wire was nubbing out into the aorta, so we decided to stop. The idea here, even though you plan these cases, so what our bailout is we have a Terumo long sheet. We have radial access. If we need to, once we cross, we're gonna do a dry seal. If we fail with the what is it called, pre-close? Well, now it's no longer pre-close. What we're going to do is use a long 8mm balloon by Terumo to go ahead and balloon occlude the external iliac or even the common femoral and hold manual pressure. So that's our bailout. So part of this is this, and I'm just going to show you with the other thing that Vishal and I talked about. So this is just an angled catheter at the level of the distal aorta or the iliac, and you can see now. Look, that's the occlusion. Now look when I take my angled catheter very slowly into this, and I inject, and you're going to see sort of this channel showing that this may be a thrombotic lesion, right? Can I have a little bit more dye? So you're going to show, so this is why, one of the things you want to look at is when you saw Vishal's, sorry about that, when you saw Vishal's angio, it was open, see? There it is, see? See the thrombus? Right. So this is fully thrombotic. So we're just going to be very careful. I'm probably going to be just able to cross with the catheter, but we'll see. Show me there it is. So see there's your aorta. So the whole thing is you really had a channel to begin with, and it was just hibernating. So what we're going to do now is I'm just going to poke this through. If it's okay with Ajit, I have Ajit here to just save me if I make a mistake. And let me see. And I think I'm through. There I am. Now I'm through, right? Yep.
Nice.
Okay, so now we're through. So I'm just going to make sure. Maybe I'm not through. We'll see. Give me a wire, guys.
Supercore?
Give me a supercore. So we're gonna pop this through. So obviously this side is thrombotic, and Ajit actually mentioned that he was a little concerned about thrombus, as was Vishal. So we're gonna go ahead.
PK,
and
thrombus. PK, if this was any other ear, if it's thrombotic occlusion, I would have probably thought, it's just a hibernating vessel. But you think this is that CAT scan was pre-COVID, that angiogram was pre-COVID? You think this is a COVID-related issue, or
nope.
You think there's a no? You're actually not. Okay, it's a channel.
Dissection. Yeah. Okay, now we're gonna have to go with a. Give me a confianza now, guys. Yeah, no, but I agree. That's a good point. And Ajit has tremendous experience with this. Ajit, in terms of thrombosis and COVID, what can you talk a little bit about that?
Yeah. So back in the first wave of the pandemic, back in March, we saw a lot of patients that presented with COVID and had concurrently acute limb ischemia. And I think there are a couple of things. So one of the things we noticed was that the thrombus was not localized to necessarily one vascular bed. So we saw thrombus lining the aorta, in the iliacs, in the popliteal, and even tibials. So it's a diffuse kind of prothrombotic state.
Ajit, did you see them in the I understand if distal occlusions happen with COVID because of the embolization, but have you seen it with major vessels like iliacs or aortic vessels?
Yeah, I've seen what looks to be primary thrombus, even just lining the aorta.
You mean dive from above?
So it's definitely can be a strange CAT scan that you see. But in terms of treatment, most of those patients we would treat with open surgery and do an open embolectomy and thrombectomy. And whether that was, the right answer, we're still looking at the data.
Right.
Because, the prognosis for patients that presented with acute limb ischemia and COVID was pretty poor.
Interesting.
Looks like you're dissecting that, right, PK? Because it looks free, but it should fly at this point of time. So.
Yeah.
Yeah, no, I agree. But the question is, we didn't do anything other than it was already probably a dissection with a
with a lesion. Probably.
So let's go ahead.
He's a young guy. You think so? Ajit, looking at this right now, what PK is doing,
roadmap.
He's a 42-year-old guy. It could be a atherosclerotic occlusion. It's always possible with smokers. But you think there is some component of vasculitis involved here, especially that we are dissecting the vessels so easily? You think there's an underlying?
I think it's an important point to consider. On the CAT scan, you do see a little bit of calcium and atherosclerotic disease, and it's right at the bifurcation. And he is a smoker, so I do think he has some risk factors. But I agree, he is on the younger side. That being said, his CAT scan didn't really show anything else, and his arch vessels and everything else looked okay. So I don't think it's. I have a low suspicion for inflammatory arteritis with everything else being okay.
It's too free to be in the dissection plane.
Yeah, look, he's flapping all
but no, I think that's a great point. I think in younger patients, you should.
What do you think about the wire movement here?
PK, you want to pull the you want to pull the pigtail back and then take a shot?
That's exactly what we're doing.
And then low mag it and then take a shot and see why is it moving so freely? Because it seems to be pretty free there, so.
Yeah, it's too free.
And then it's getting stuck right here.
Yeah, unless we are hitting a wall or something.
Yeah, a plaque or a wall.
Yeah.
You know what? Why don't we do this? Why don't I track this up further? Come, show me down.
And then put a
A safer wire.
Safer wire, like that's fine. Supracore is fine too. So, and now take
give
a picture.
Me a little dye. Okay, we definitely look like we're in the vessel here because the catheter is moving freely.
Yeah.
Let me check a pressure. That's another thing we could do. We are getting blood back or no?
Soft tip wire to see if
we're getting blood back. We are not getting blood back. Right now, I'm not worried about the ACT. No. Actually, give 1,000, Liz. Nope, not getting blood back.
Interesting. Okay. Ajit,
I think
another question is, let's say if you have difficulty crossing from below, right? Would you put a 6 French long sheet from the radial, cross it from above, balloon it, create a channel on both sides,
give me
and then wire from below and do the case?
Yeah, I think that's definitely an option if you're having trouble crossing from
below
the lateral side.
Yeah.
Well, remember, guys, the one thing that did happen was the wire jade as we were trying to do the pre-close. So that may be the issue here, and I think that's part of the issue that we may be facing here. Now I'm getting free blood. So at this level.
Yeah, but to answer your question, to answer your question, I think if you can't cross from below, crossing from above and then snaring the wire, or even getting into your catheter from below, is a great idea. And the other option here, which is something else we discussed, is even if we're only able to cross one side, still use the option of doing a fem-fem afterwards.
Fem-fem and then afterwards. Makes sense.
Yeah, so that's kind of the backup options that we were discussing.
Oh, 100%, yeah. But this is very strange to me that we're able to, you have a channel that we saw. We know that the pre-close wire jade in this area. So I'm thinking, is that what's happening? And the question is whether we go, watch out, you have blood on the ground?
No, that's not.
Let me see here.
Ajit, now that you're in the room, I have another question. In this case, clearly it's atherosclerotic. We know that. So it's easy to match the sizes of the stents. I'm sure you're going to use like 23, and then go with the same sizing and easily do it. You get a good seal for the syrup. But if you have aneurysmal aorta and you have a normal atherosclerotic iliac vessels, what would be your way of dealing with things?
Interesting.
Yeah, no, that's a great question.
Because there's a big mismatch, right? So.
Right. Yeah, so I think that's an important point to consider. If you're dealing with aneurysms, then seal is extremely important. And so in those cases, you really want to oversize at least 15 to 20% to make sure you get seal proximal and distal.
Okay.
When you're dealing with occlusive disease, it's almost a more to 1-to-1 ratio because obviously you're not trying to seal, you're just trying to create a big enough lumen to resolve the patient's symptoms. But in this case, it's not, there's no aneurysm or nothing like that. So we chose, we're planning to use a 23 millimeter cuff, which is one of the smallest cuffs that smallest cuff that Gore has, which will be appropriately sized for the aorta here.
Yeah, look. That was it.
This is it. It's going into a branch, PK, right here.
Yeah, see how it goes?
Unless that's behind the aorta, which is very unusual to happen. But
it looks like a dissection.
Yeah, it's like a dissection, no?
Yeah, it looks like it's just. What about now?
No.
Show me above.
It's a loop.
So what? Yeah, you're right.
Are you above the renals, you think? Or?
Yeah, I'm above the renals now. That looks really strange. Okay, come back down. Yeah. So interesting.
Yeah, I think sometimes in the aorta, because it's a much bigger vessel, it can the catheter can twist freely.
PK, at this point, would you try to cross from the left once?
That's what I'm going to do, and then balloon it.
Yeah.
That's what we're going.
And balloon it and see if you can create a nice
Okay,
channel.
give me another vertip catheter, guys. Okay. Here. So let's give it another vertip.
The other option, which isn't an option in this case necessarily, but if you have a more distal occlusion, then you can try to cross from the other contralateral femoral too. It's you obviously don't have the support that you would have coming from above, but it's another option to consider.
Yeah, I mean you can create a channel into the distal aorta, put a UF catheter, and try to poke it from the other side and see if you can get in.
Yeah.
Let's just cross first.
Yeah. Give me 1 second.
Well,
PK, you might be right, PK. When you put a J wire, it might have created a.
Oh, actually, I want the die. Give me the die, guys. So yeah, I think that's what happened. It was strange because Vishal and I really felt this was going to be an easy cross, and then it's interesting that we're struggling like this. Of course, it always happens when you're live, but it is what it is.
How do you factor in when you would primarily come from above and try to cross these lesions? Now that we have longer balloons and stents, is that something that you consider? Or is that more of a backup option for you?
What's that, come from above?
Yeah.
I mean, to me, I mean, we can put a 6'7" slender or 5'6" slender, whatever it is, come from above and try to cross. But this one, I'm so surprised, Ajit. I really am. I'm shocked.
Right.
I'm really, really surprised.
I think that meniscal thing was probably more of a dissection with a thrombus on it. I think that's why.
But I mean, why would it dissect? You didn't try to cross it at the other place, so if you try to cross.
Ajit, I don't know. Unless it's more like a distal common iliac or some lesion. Crossing from above, I don't know if it's probably the most, unless you have access from below. PK, there was a small channel coming from below, right?
We did see that, but we just want to see how this wire behaves.
That's probably the channel, that's the one I'm saying. That's the one.
Well, it's not behaving like there's a channel there.
Should we shoot from above and see once?
Yep, you can shoot, but it's a long occlusion. There it is. That's the channel, I think.
Yeah.
Little die?
Uh-huh.
No, we're quite far away. Give me some some dye in this. Let me do something here. I'm going to take the catheter up a little bit, and I'm going to give a little injection because there is a channel, like you said. Right. See, there's a channel.
That's probably a channel. A little bit more lateral, right there.
That's probably the channel.
Yep.
Let's take a DSA picture, see what we're dealing with here.
Ajit, would you do this radial or?
No. I would definitely, approach it similar to this for kind of the reasons you mentioned. I think you're limited, if there is if you do need to place a covered stent, or if you have any issues, it's going to be hard to do it from a radial or brachial because you may not have a big enough sheath for some of the larger covered stents. So I do think
not really.
If I'm going to do endovascular, I start with femoral
look
access.
Look at the stain. I think it's all thrombus.
For something in the external that's like just a stenosis or maybe not so bad, where I can put in a bare metal stent potentially, then I would consider doing that primarily from above if there's...
From above.
035?
Yeah.
Got it.
035 angle, stiff angle.
We access the femoral so often that's kind of my
go-to.
Ajit,
you think that staining is thrombus, or you think that's a dissection, or?
It's not really staining a lot. I think it's thrombus. See, it's almost gone.
Yeah.
Okay, that's your
I think it's primarily a thrombus because we have imaging from before where there was a channel. So I do think there is
now your wire of choice. I mean, we generally go with 0-4, and we preach that, me and Vishal and Karthik, especially because we really believe this closes by fenestrations. But right now, I'm going to go with an 0-35. Would you go with an 0-35 at this stage?
Yeah, definitely.
Okay.
I think especially for iliacs, I even sometimes primarily I may start with a 0-35, like a glide wire, quick cross, 0-35 quick cross catheter, to cross some of these tougher lesions.
Do you J-loop it, or how do you do it?
I try to do what you do, which is try to find that channel and see if it'll go in easily, because I think that's the most atraumatic way of doing it.
I agree.
But certainly if that's not working, then I think J-ing is an other alternate technique that may work well. The problem with that is you can end up in a dissection, and
you can dissect up the aorta. Because at least before we had even if we dissected on the other side, it's an 0-1-4 dissection. Here, it's
but in that case, you can actually use a reentry device. I mean,
well, that was my next question. That was actually my next question. How often do you use? No, it's a great question. Are you kidding? How often do you use reentry devices in these cases?
I mean, they are not approved for this indication, but there are many reports that people do that actually, and the Pioneer I would favoritize the Pioneer in this case, because here you have a delicate position where you might be in bigger jeopardy if you poke the needle in a wrong position. Therefore, I think Pioneer would be a valuable option. Other devices might be like an Outback or
well, yeah, Pioneer is one, Outback is another. You know, this is another dissection plane now.
Yeah, I've used the Outback a few times to kind of re-enter into cases like this, but certainly I feel much more comfortable using that in the SFA and popliteal than in the aorta.
So Ajit, there is an IMA coming right at the level of the occlusion, right? You were going to cover that, right? Because SMA and celiac is fine.
Yeah, we may have to, but yeah, even if we cover it, I think in this scenario it's going to be completely fine, because one, it's a small IMA, so that you know, that tells me that probably it's not an important collateral to the gut or the pelvic area. The hypogastrics, SMA, and celiac are open, so that's also very reassuring. And additionally, when we do AAA repairs, aneurysm repairs, and EVARs, we routinely, you know, seal off the IMA anyway, and you know, as long as those other vessels are okay, you know, the patients don't know the difference. So.
Well, you know, this is interesting because, you know, this is now becoming more challenging. So the question here would be is what would the now when how much attempt do you give before we go to the to another avenue? Before we try to cross from above, because I mean, our goal, like I said, was to treat this completely percutaneously, but it looks like now we may have to convert a little bit to an aorto-bifem versus a
that's good.
No? Dissecting.
Can you give us a stiff angle?
Not moving. What's that? Ray is giving give me a little die.
Yeah.
Yep. Nope.
We can.
Yeah.
What's that, brother?
The other way to do it is try to dissect it from below. We're going to put two covered stents on both sides, so I think dissecting
I agree.
is not a bad idea. You can try to dissect it. If you cannot, just put a 6-inch sheet from the top and 5/6 lander, and then, you know, just try to cross from above.
Yeah, that would be the next step. Yeah.
Yeah, and just use a 6-0 balloon, create a channel, and then just work from below.
Oh yeah, that's the next step, is to put a slender, get it.
Yeah.
At least balloon it from there, create a track, and then.
All right, guys, get a slender down, and Vishal try to get a slender in while I keep working with the JIT here. Let it get. Okay, this looks better movement here.
R2P sheet.
R2P.
You know, PK, the loop you had with the 035 wire was a good loop.
Yeah.
That's a good spot. The way that right there. Yeah, I think that's a great spot.
And then you just have to break it.
No, it's on the side. You see that? It's not moving at all. Let me try to change the direction here. Nope. This kind of looks like the what it would say going off to the side again. So, any thoughts, Ajit, now on your end?
Yeah, I mean, I think trying to cross from above would be the next step here. We can discuss more,
even if you create a big plane from below with a loop, I think it should be fine, because you might be able to enter into that plane from above, you know.
Okay, give me the overnight wire now.
Yeah.
Give me the Turuma go. I think
So
it's
it's
better
totally
to do
fine.
a loop. Yeah.
Yeah. So you create a plane, because at least when you come from above, it makes it easy for you to get into that plane.
Still surprised the right didn't go. I'm gonna try that.
We're so surprised. We're gonna keep trying. While Vishal gets the R2P there, he's gonna try from the right. I'll try from the left. Okay. As long as one of them crosses, it'll be wonderful. I mean, Ajit, any other wires that you would try?
So usually I start with the glide wire. That doesn't work. Sometimes I like to use a V18 as well.
Let him see. It's okay.
Command wire.
It's okay.
That's fine.
Yeah,
That looks like fine. That looks pretty okay, PK.
Yeah, it just looks like it's going off to the side.
Give me one more Turuma
I
go.
don't know, I think looks fine to me. I mean,
Yeah, it might just pop in. You're right.
yeah.
You ready, Ray?
No, it looks like a branch.
Let's go.
Yeah.
I doubt
Looks
it.
fine. That looks fine to me.
This looks better.
That looks fine to me. Yep. I mean,
There
pop
it is.
in, I guess.
I
There you
think
go.
we're in. I think we're in. We'll see.
Yeah.
Definitely looks like we're in. Yep, we're in.
Nice.
Yeah.
Show me above, save that. All right, let's go make sure that the wire moves nicely in the aorta.
Vishal, I think we're okay.
No,
yeah, I mean,
no,
you can.
that's why I didn't go exchange.
No, I think it's fine. You can still put the sheet, Vishal. It's okay, even if you have to do it.
No, I don't want to.
No, we're not fine.
Yeah.
That's unbelievable that we got.
You probably went into the same plane from this side also, PK.
But how is it possible?
Which is very unlikely. I mean, how can the both planes connect from?
No, I didn't.
No.
All right, let's get the R2P, guys. Let's go from above. Let's not waste time. So I am going to keep this up to here because I think I'm in a good spot. And I'm going to keep trying. Give me a little dive from above, Sriya.
Might be actually a good position to keep it
trying.
for the reentry device later on.
A little dive?
Yeah.
Okay, this is reasonable.
Yeah, that's a good spot.
From here.
PK, you want to put the same thing wire on this side also?
Yeah, I have the wire this side. I want to try from the right side. I'm very surprised that it doesn't go. I'm sure.
Yeah, we're both
if
very
you're
surprised.
persistent, I'll exchange the sheet. But I think
PK,
I'll give the right side one
I
more
guess
attempt.
you use you have a that's overnight, right? Teruma gold, right, PK?
Yeah.
So leave the wire there, and then get the wire from this side also, and leave the wire there.
Here. I can help you with this.
I mean, Karthik, this thing is moving so freely.
Yeah,
That's what I'm
I'm
saying.
surprised that it's not in. It's probably a big plane.
I think we have
now
to.
we are in. Now
I don't
definitely
know,
it's
buddy.
in. No, it's in. It's in. It's definitely in. It looks like it's in. No.
Yeah, now we're in. Yeah,
Now we are
that's
in. Yeah, it looks
that's
like
in.
it's in.
So what do you
no?
want?
Yeah,
We're definitely in.
you're way above the
no.
level of the renal, so
Yeah.
yeah, definitely you're in.
Yeah, we're in.
Yeah.
Okay.
You're in.
Okay.
So you want the
Great.
R2P or no?
Yeah.
Let's hope.
Let's hold.
Yep,
Okay.
good pressure.
All right, let's go back with the
Good blood flow. Okay, let's now get the let's show the aortic pressure.
Yeah, probably we should do the
Damien,
same
can
thing.
we-
Form a
can
loop
we-
on
Yeah, I
the
want
right
to try
side
it
also,
right
and then
from the
go in.
right side. Exactly. I have
Yeah.
the overnight wire ready.
Yep, Vishal's going to get started on the right side.
Let me
Damien,
put
did
my
you see the
pigtail
pressure,
back
buddy?
in just for my reference again.
Let's make sure. Okay. I have aortic pressure on the right side,
Okay.
on the left side, and Vishal's going to try on the other side.
I think
All
you
right,
should
so-
start ballooning, PK, on
Yeah.
on this side.
What do you think, Ajit? You want to start ballooning? I think we have to upgrade the sheet first.
Yeah.
Let
Yeah.
Vishal give it a few attempts because, look, the idea here is why upgrade the sheet? This is the way I look at it. If right now you got to think about this gentleman as a claudicant. Plus, you want to think about his safety. He's not going to die from this aorta, right? The point is, if we balloon and do crazy things, we could create problems. At this stage, he can have a very safe fem-fem. He's a low cardiovascular risk. Ajit can talk about actually Shreya is going to talk about the patencies of all these other things.
No, but PK, still you're going to, even if you want to do a fem-fem, now that you
understand.
crossed on the left, you're going to put an aortic stent on the left, right? From the left.
No, you don't need to know. Well, we could do an aortic stent. We could do other things as well. But the point is, I think let's first give it an attempt before we balloon, is my point. Right
Right.
now, everything is under control.
Okay.
There's no reason to balloon. I think we're very under control here. It looks like, God, well, no, it's more like the...
Same plane, PK. Vishal.
Let me fill my catheter. Hold on. Let me fill my catheter for you, Vishal, so you can see my catheter.
See? So way it moves.
See my catheter? There you go. You're in. Come on, baby.
I don't know.
Let me see. Where's your wire? Come on, baby. Yes, Vishal Kapoor. Show off Vishal Kapoor. All right, ready? You gotta love Vishal Kapoor. Everybody, I want you to please send Valentine's Day cards to Vishal Kapoor. Snehi will be very upset. Ready? Okay, ready
I'm
now?
sure you called him baby, so I'm sure Sneh is already upset. So.
All right, we're gonna show aortic pressure on both sides.
PK is going to get a text from Vishal's wife, you know.
I know,
Nobody calls
Snehi's
him
gonna be
baby
like,
except
"What?
me.
Except me. Actually, his beautiful daughters. I don't know if Karthik, but we're getting a little blunted waveform here. Let's see.
It's fine. But they look like they're definitely in. You want to reduce the size of the image
No,
and see
we're in.
at
We're
what
in.
level we
Okay,
are.
let's get two supercores. Great job. Okay. 2 supercores. All right,
Vishal,
now
I'm
we're
proud
in.
of you, Vishal.
Thank you, Karthik.
See, it's interesting how you're proud of him. He's the one who just created the dissector plane with Sriya.
Oh, now he's...
Okay, and then him and Sriya
Karthik
crossed
again.
to show
See,
off that they did
as-
it.
It's all part of the plan.
You know,
Right,
PK,
it's all part of
as-
the plan to make me
it's-
look bad.
You know,
Karthik told me to do that.
Yeah, it's a Sinai motto. No, it doesn't matter how much you screw it. As long as you fix it, you're the hero.
All right,
So-
so now we're going to do a pre-close. So Shreya's going to do her first pre-close live. So with the coaching from Vishal, so everybody's going to learn how to do this. So the only question is, before we do the pre-close, we're going to balloon this. Ajit, are you okay with that?
Yeah, I guess my question would be, where do we think we re-entered? Do we think we re-entered in the aorta or the iliac?
The aorta. You know what? But no, we have to balloon the aorta though. We have to.
I'm just thinking about putting in a cuff in the aorta. You know, if we re-entered into the aorta, I'm almost thinking maybe it's safer to just do kissing stents, because I worry about putting in a bigger 23 millimeter cuff in a partially into this dissected part of the aorta.
But
I
so
agree.
you won't have
I agree with that.
have a good seal, you're saying?
Yeah, I don't want it to be compressed. If there is
we could do an IBIS.
Yeah, we could do an IBIS, take an angiogram, and then kind of reassess.
All right, so we're gonna maybe you can explain it to them so the people at home
right
can
side
have
look
it.
iliac, but the left
So
side.
give me an IBIS,
PK,
please.
I think I was about to say like what Ajit
Right.
said. I don't think aortic cuff is probably a good idea for him. Because of the same reason as what Ajit said. I think that cuff might get compressed.
Spartacle.
Yeah, well, I'm thinking about a couple things here. So number one is if we re-entered
that's
somewhere
a
in the
dent
middle of the
Yeah.
aortic occlusion,
Yeah.
then when we put in a big 23 millimeter cuff, you know, that could potentially lead to, you know,
Honestly,
whether,
I think we're entered in the distal aorta. We didn't go side by side. We hit the ostium and we went.
Yeah.
We can do an IBIS and we'll do an aortogram and you'll see. So we're changing out for a 014 Spartacore now,
Yeah.
and the Spartacore is going in. So basically, for those at home, while we do the IBIS, I'm going to have Sriya go over the different surgical options and go over a presentation as we do. We work quickly. I know you guys saw us struggle for a little bit. And Vishal create a dissection and then cross it. So go ahead,
Yes.
Sriya, you're up.
Yep, one.
I'll take it.
You like that?
Yeah.
Create a dissection and then cross it.
Thank you.
Go ahead, Sriya. I'm sorry.
Vishal, you're still the hero. Don't worry. Shreya,
He is the
Shreya, go
hero.
ahead.
So just in aortic iliac
Damien.
occlusions, I just want to review some anatomy. In the abdominal aorta, as you all know, the
Walk this out.
Yeah.
Nice job.
major branch is the celiac
No
trunk,
kidding
which
aside.
is supplying the stomach and the spleen and liver,
No, of course
followed by the adrenals and renals. We also have the gonadal arteries, superior, inferior mesenteric, and this and the last branch of the abdominal aorta, the median sacral artery, coming off right at the bifurcation.
What's the heparinization?
After the bifurcation, we have
2,000, 2,500
branches of the internal iliac, which supply the gluteal and sacral and the rectum, and also the medial aspect of the thigh via the obturator artery as well.
That's the wire.
And also you see the branches of the external iliac here on the left, the inferior
2,000, please.
epigastric, superficial epigastric, and the deep
Perfect.
circumflex
Damien,
as well.
live.
And the anatomy is important because in a lot of aorto-iliac disease, symptoms, the onset of
arterial,
symptoms
please.
are usually well beyond the
supracore for
beginning of the disease.
Record.
And usually there's
Back up.
development of collaterals from, supplying the branches around the occlusion. The main collateral vessels that we have are the iliolumbar system, the epigastric system, and the gluteal obturator system that connect various branches of the abdominal
Can't see
aorta and the iliacs. And also
The game, please. I can't see anything.
descending aorta into the iliacs and CFA, and also within the iliacs and the CFA and profunda via the gluteal obturator system. There's also, here you see on the right, a big collateral called the arc of Riolin, or the Drummond artery, where you have a connection between the SMA and the IMA, which is usually also indicative of SMA and celiac artery occlusion. And then you also have various visceroparietal connections and connections between the gonadal arteries to the internal iliacs as well. This is just an illustration of what we were talking about, the two in the middle being the iliolumbar collaterals that connect the branches of the aorta to the iliacs, and to the left, the epigastrics connecting the subclavian to the iliacs, and to the right, the median and lateral sacral collaterals as well that tend to form in case of pretty severe and end-stage occlusions as well. So in terms of procedural considerations, obviously the task classification plays a big role. Task A and B most definitely always endovascularly managed, and task C and D recommendation is for surgical, but there's more of a trend towards endovascular first approach even with the C and D lesions, which I'll go over. Other lesion characteristics, tortuosity, like we talked about, access, any concurrent disease in the renal and mesenteric arteries, presence of any aneurysms, and also multi-level disease, and CTO also plays a role in procedure planning. So in general, task C and D lesions, the recommendation is for surgical, and as Dr. Rao had mentioned, the gold standard is usually aorto-bifemoral or aorto-iliac bypass, which can be pretty extensive, associated with pretty severe complications, cardiovascular, ALI, bowel ischemia, etc. But the patency rate obviously very, very good, 85 to 95% at 5 years. And also up to 75-80% at 10 years. Other surgical options, aorto-iliac endarterectomy, which less commonly done now, and also extra anatomic bypasses, which usually are reserved for high-risk patients with pretty diseased abdomen. And more recently, also more of a push towards a hybrid approach, and especially in the case of common femoral and iliac disease. In terms of the task C and D lesions, more of a push towards endovascular intervention. It comes from the Bravissimo study that looked at 24-month patency rate in task A through D lesions, and found no major difference between endovascular and surgical approach in terms of patency rates and primary outcomes. In terms of the endovascular therapies, a few options for aorto-iliac stenting. We have self-expanding and balloon-expanding covered and bare metal stents, and also aortic stent grafts that I'll talk about. Some data in terms of our endovascular tools that we have. The COBEST trial that compared covered versus uncovered bare metal stents. Found that covered stents tended to do better in terms of long-term patency and clinical outcomes. And the benefit of using covered stents is not only to possibly cover for any kind of complications that you may have in this, especially in a high-risk anatomy, but also better patency rate due to possible less neointimal hyperplasia due to a PTFE barrier between the wall and the lumen. And in terms of bare metal versus self-expanding stents, we have some data from the IBIS trial that compared the two in a randomized fashion, and found that the self-expanding stents tended to have better outcomes in terms of restenosis and freedom from TLR as well. And this we've gone over in prior sessions as well, the difference between the two, bare metal, higher radial strength, more accurate deployment, and the covered stent can obviously be a barrier towards, especially in the case of plaque prolapse and thrombus migration, can prove beneficial. And self-expanding stents more of a role for areas that are more prone to movement. They're more conformable.
Clean it up, bro.
They, however, are subject to crush. Some options of covered stents that we have that are bare metal. We have the VBX. We have the PTFE covered BARD, atrium, and also the B graft. And generally, in terms of comparison, we have data from one study of 24 months showing, in terms of the primary composite endpoint of overall mortality and cardiovascular events, maybe the VBX does a little bit better compared to the other ones. So I know we've been talking about, do you want to kissing stents? So this is essentially, like we were talking about before, just bringing two bare metal or covered stents up to the ostium. There was one study that looked at patency of kissing stents in about 250 patients and found that the 5-year patency rate was no difference between the two groups, whether it was precisely at the aortic bifurcation versus the stents that were not exactly at the bifurcation. 5-year patency rate about anywhere from 70 to 75% and no real difference in complications. However, one drawback to the kissing stents is protrusion of the stents into the aorta, which theoretically could increase risk of thrombus formation and neointimal hyperplasia. The CRAB technique, we spoke, yeah. We have a prior live case about the CRAB technique, essentially dual femoral access, and where we're basically taking 2 VBX grafts, 3 VBX grafts, an aortic graft and 2 iliac grafts, and essentially creating a bifurcating stent graft.
Exactly, bifurcating carina.
In that case, the aortic graft, which we used in the last case, can be post-dilated up to 16 millimeters. So in case of larger aortas, this might be a better option.
This is the challenge. Yep.
In fact, we do have some data in about 130 patients with predominantly task D lesions undergoing the CRAB technique, and at 3 years, patency was around 82% versus surgical around 90% at 5 years. There was an improvement in ABIs and also clinical outcomes in these patients. Improvement in ABI from about 0.6 to 0.9 post-op, and this was maintained throughout 24 and 48 months of follow-up. We also have...
Actually, let's stop there, because the AFX system is probably going to go out of service right now. But I believe that they're not going to do that, so it's really not worth talking about. So, okay, so now we've crossed. Now I want to play the IBIS. So we did an intravascular ultrasound, and Ajit, maybe you can talk about what your thoughts are and what you're looking for in the IBIS.
So on the IBIS, I'm looking for a couple things. So number one is to see if we're intraluminal, see if there's a dissection flap, and if there is, to see how much we're in the dissection versus the true lumen. I think number two, and here we have a CAT scan where we can see the sizing, but IBIS is also a great way to size the aorta and the iliacs. And then you can look at, the amount of calcification and see, you can mark out where the bifurcation is, I think, which is helpful because in this case, the whole area is occluded. So maybe.
So Damien, can you play run 2? So I want to show you this in run 2. So I think one of the things we're really concentrating on is whether or not we were within the dissection plane or within the aorta, because that's going to be a big difference. Run 2, Damien, maybe run 1. Play run 1. So you can see here that we're starting from the proximal aorta and we're pulling down. Can you just fast forward it a little bit?
Yeah, can we show the IBIS, please?
Show the IBIS, please. Image. Yep, thank you. So as you see, we're coming down. You can see, Karthik, that as we get close, you can see there's the lumen, the narrowing, and there we're within the vessel. But we're not sure whether we're in the dissection plane or not. And you can see right there, that's the dissected iliac, and then you're going to pop right into the occluded iliac, and then you're going to pop into the common iliac in a second. So we went back and looked at that carefully, and see, there it is. Now that's the common iliac. So we went back and look. I'm going to push it back in, and we're going to look at it carefully, and you can see we're not certain whether we're looking at the contralateral iliac or is that a dissection in the aorta, because it's a right there, because it's a big deal to us. In terms of placing the aortic cuff. So Ajit, can you talk a little bit about what you see and whether you think we should use an aortic cuff here or not?
Yeah, that one area that we're talking about, it's hard to see if that's the true lumen, false lumen, or if it's just the contralateral iliac. I think what may help us is if we balloon to create channels, and then we can see if there's a dissection flap in
so give me a 6-0 balloon, guys.
In the aorta iliac segment.
So Ajit, we have a question for you
right now
specifically. I know now that I think in your mind, if I'm not wrong, knowing you, I think you're probably tending towards two-stent strategy. But the question is, what would be the two-stent strategy, and would you know where the neo-carina is going to be, and can you reach that carina? Can you make a proper carina for the patient? So I'm assuming the question is, can you seal
That's it.
the proximal ends very well?
So the
If
behavior
we
of
were
the
to
wire
do
itself.
kissing
Kissing
iliac
current,
stents.
yeah,
Little
yeah.
picture.
Yeah, I mean, I think, since this is an occlusion, I'm not worried so much
Perfect.
about sealing and excluding the occluded aorta.
I like that.
Just looking at the angiogram here.
Right?
So I think
Can we
even
see the
behavior
angiogram,
of the
please?
wire as well.
Show the angiogram. The wires are to the side. That's one of the things that bother me.
Yeah,
You know, the wires are to the side. You know,
it could be a parallax too.
you know, but it looks like it actually looks like the aorta is turning there.
Correct.
Because
exactly.
to me, you know, both the iliac wires are straight and they're confluent with the iliacs. I think that's the
Exactly.
aortic turn. But I'm going to balloon here, Ajit.
Yeah, I think this
All right,
is a good area.
Lizzie, going up.
So to answer that question, I think the most important thing is creating a large enough lumen where we're going to resolve this patient's claudication. So, even using, 8 or 11 millimeter VBXs will be enough.
3,
even if
4.
they're not necessarily fully opposed to the wall, I think that's okay as long as the proximal
5,
segment isn't crushed and it's fully expanded.
Right.
7.
What are your thoughts?
8.
I think I agree with that. I mean, at this point of time, looking at the IBIS, I would probably tend more towards
Down.
bifurcating
Walking
aortic
back a little
stents.
bit.
I'm not concerned about the right side iliac
Go
wire.
up there.
I'm concerned more about the left side iliac wire.
No, actually, left side iliac wire looks quite
Yeah.
parallel to it. I mean, to me, the way it entered. We can do an IBIS on both. But I don't
Yeah, I
know.
mean-
to me, I don't want the mismatch in the aorta. So I'm very particular about that mismatch. But let's see after the balloon how it looks.
So
Down.
it was 1.9 in the distal aorta, and then the iliacs were both 1.2 and 0.9. Is that right? Am I right with the
Correct.
measurements, Shreya?
Yeah.
Yes.
Right?
Yeah.
Okay. So even if you
Yes, sir.
use 11 and 11 PK, you
Leave it
can
on?
still get
Yeah,
the
I'm
proper
leaving it.
sizing on both sides, as Ajit was saying. So you can attain your 22 nicely in the distal aorta.
So we still haven't opened up enough.
Yeah.
So I'm going to go further into the aorta. See, now we're going to have to balloon further in the aorta. Okay, let's go up
Right,
here.
Vishal, Ajit, am
No,
I
I
right?
agree.
So
I agree with you. I mean, in this case,
Yeah, the other option is to land the aortic cuff a little bit higher once we know we're clearly in the aorta and intraluminal. So that's another option because we have plenty of room between the
renals and the
renals.
and
Exactly.
the IMA. Okay.
4, 5, 6, 7. I mean, the way the balloon behaves.
Okay.
8. I
Down.
think it looks well expanded. But it's a 6 only. So.
We have 8 as well.
Walk it back. It's a very small balloon. So now we're going to walk it back, watching our pressures. I would walk it into the sheet.
Yeah, it's still.
Okay, ready?
Ray,
DSA?
you want to push your okay, the thing down a little bit more.
Still not getting any flow.
Damien, can I get contact?
DK, you want to push your pigtail a little bit down and see?
It doesn't matter. I think
antigrade
that there's no antigrade flow right now.
Yeah.
So the only question is, I can take the pigtail all the way here. I don't think it really matters.
Yeah.
Ready?
Yeah.
We
Hold on one second.
might get a trickle, but I think we need to figure out why this is not happening, and then decide how we're going to deal with it. I mean, this is the problem with aortic work. I mean, there's so many planes. It's such a large vessel, you know. See?
So definitely that doesn't look like a regular plane, right? It looks more like a dissection plane. But it doesn't matter even if you're in a dissection plane. I
Right.
mean, I don't think it matters.
I think you see a hint of it at the end.
I do see the
Yeah.
hint of it at the
Yeah.
end. So what do you think we should do? I mean, I can be, but I
So you
just,
can see the hint coming right there. But yeah, it's probably a dissection plane.
it's
like you said.
probably definitely a dissection
Yeah.
plane on both.
Both
Yeah.
sides.
Yep.
So I would
Yeah.
I'm thinking just kissing a
Yeah,
little.
I think we're
Just kiss
kissing
it
now.
down.
Because
Okay.
I would probably
Seven
go with
French sheet.
eight and eight
me
balloons,
a-
7 French
yeah.
sheets, and then
Yep.
do
Yeah.
Yep. Let's have
bilateral
let's have another
kissings.
725 and give me an eight
So,
two
Ajit,
seven
what stents are we going to
Uh-huh.
use?
XLs. We're going to use two
You want to use
757
an
XLs.
8 or a 7 French?
Well,
Yeah, and then we'll-
857 doesn't go through a 7 French.
No.
Does a 757 go through a 7 French XL?
It does.
No, I think it goes through an
No.
8 French.
We always have the
Yeah, I think it goes through an 8
729s
French.
and
Give
39s
me an
go
8
through a
French
7.
25. Where's our gore guy?
I thought they all.
Decided to go get a coffee?
I think 8 is fine. They're big,
Maybe
they're
two
big
coffees.
common femorals.
Can you look
you
at
can easily
the-
perclose both. So
Yeah.
The 857
The,
XL.
so Ajit, you're going with both 8s on both sides.
Yeah, we're going to start with the largest
857
VBX.
XL, what sheet?
Because
Look
the
at the
iliacs are over
857.
10
Yeah, 8.
millimeters, and then we'll have to post-dilate
Yeah.
the
Oh, 8 French. I
VBXs
think 8 French is
afterwards
the best thing
to
to
get
do.
them appropriately
Or is it
sized for the
Talk
iliacs
about
and the
Labrador.
aorta.
Yeah, okay.
Here's
So
one.
you're going to make them go. You're going to make it proximally in the iliac from the aorta, proximally in the aortas go down to like 11 on both sides.
Well, with the one stent that we're using, I think
This is
we can go up
23,
to
right? Yep.
16.
Yep.
So probably even a little higher than 11, maybe even 13 to 15 in that range.
Because you
would
have
be
1.9, 1.9, right, in the distal aorta.
Yeah, around 20 millimeters or so.
So you might want to reach 2.2 or 2.3 on both proximally
This
through
one.
both ends.
I think if we hit 12 to 14 in that range on the proximal VBXs, that'll be more than enough.
But I think there's going to be a gutter behind the VBXs.
Yeah.
You know, I really do. Ray, we need a
Yeah,
little
what
nick.
are your thoughts? Are you thinking about going higher
little
than
nick?
that? Going to
I just
16?
think
No.
we're gonna run into a gutter. We need a
Yeah,
nick. Ready?
I think
Hold
I
pressure.
was thinking of more like 14 and 14 on both sides,
Pull it out for him.
just so that reduce the
Oh,
amount
no,
of gutter
let him-
as much as possible.
Pull out the
Yeah.
table.
The other thing I'm
Oh,
thinking
sorry.
about is this
Oh, you wanna
patient
keep it
clearly
on
is
that
has very fragile vessels and clearly dissects, and it's not like a very hard calcified vessel based on the CAT scan. So I think being more conservative and not doing the cuff is also probably the right decision here.
Okay. Well, listen, I think it's a
Because
good.
the last thing I want is because the cuff is a little oversized compared to the
Use the
aorta.
Now it's going.
It's a 23 millimeter cuff
That's
to 20
Yep, that's
millimeter
it.
vessel. And
Crashing
so,
on the- yeah.
Okay,
yeah,
that's
so if
good
this
right
patient
there.
has, fragile vessels for whatever
that up.
reason, then I think that's a
Sorry, my
risk of
friend.
creating, a dissection or a rupture, things like that. So I definitely think doing the kissing iliac stents is the better decision.
Our wonderful Go rep had just had his coffee, and
He woke up.
he's here. So I guess listen, guys.
Take
I
this
think
out?
in this case,
Let's flush the sheet. Give me.
I told what I said was very important, and I think all of us kind of have that same feeling. Can we walk out the this one?
balloon.
Yeah.
So we're going to upgrade to bilateral eight stents, and then we're going to go ahead and a little pressure, and then we're going to go ahead and breathe out, breathe out, breathe out. You're fine. And then we're going to go ahead
One last
and we're going to
time.
do another bilateral balloon, or should we just stent it, Ajit?
I think balloon.
After just pre-dilating with a what size balloon?
We
Oh,
just
the
did a
6.
Yeah, I would just put in the stents right after.
Yep. So
way-
you want to do a bilateral kiss now?
Yeah.
We
Okay,
have
let's
balloon
get
on the left side.
another 6. I need a nick, guys.
We balloon the left side too?
No, not
nope,
yet.
I need a nick.
We have to do.
Can you
balloon.
pull it out, please?
Yeah.
Pull out.
Yeah,
no,
because in
pull
this
out.
Yeah,
case,
I
we
got
almost
it.
want the thrombus to keep our iliac stents in place, right in the plaque, so that way they don't
Can you give
migrate
another round list?
until we
Little, bro?
post-dilate them.
Thank you.
Right over here. Okay, breathe, Flora. Okay.
So for kissing iliac stents, are you routinely using VBXs
good.
now, or
No, I mean, I think VBX is overused in my opinion. I think that we need to use, be economically fiscally responsible. I'm sorry, my friend, fiscally responsible as well. And I think VBX in every case is very, very expensive. But these are the cases that VBX is a great stent, a great lifesaver. So let's get 2 6-0s on both the wires. So we're going to now take 2 6-0s into the aorta and balloon. Now, I just want to make sure, again, for everybody, we have the aortic occlusion balloon around, guys.
Yep, I
Right?
brought it.
We have the aortic occlusion balloon, and I think for all the cardiologists out there, this is the area where you got to be very, very careful. The surgeons, yep, 680s are fine. Well, I've got whatever's going in here. On the other side, 680 is fine. So, so I think we need to have the aortic occlusion balloons, and we also need to make sure that we have, our surgical team.
he's
Obviously, we
giving-
have our team here. They're aware of what's going on. You never want to call your good friend who's a surgeon at the moment of the rupture, or God forbid anything like that, and then tell them please come and help. They should be aware that these kind of patients are being done in the cath lab or IR suite. Doesn't matter, because at this stage, this is a life-threatening situation that can occur. So we're going to go ahead now. Aortic occlusion balloon is in the room. I'm just going to go a little higher, like right here.
Yeah.
Yeah.
Definitely.
Okay, I'm going to pull the pigtail back now because I don't want to hurt my pigtail or hurt the aorta with the pigtail.
Go forward.
Okay, ready, guys? We're going to go up, Lizzie.
Going up. Slow.
Going up. Nice deep breath, my friend. Relax. Everything is wonderful.
2,
This goes.
3,
Uh-huh.
4,
4,
Uh-huh.
6.
6.
6. Okay, save that image. Leave it up for a second. What's the matter? What does it hurt? He's got the hiccups. Okay, down. Walk the balloon, both balloons back. And let's go up again. I'm fixing my sheets. Okay, let's go up right there. Go up right there.
So the main reason to do this is just to create a channel for our stents.
Yeah, this is good right
So
there.
that way they track
So
easily.
walk the balloon back, Shreya.
Yeah.
Actually, that's good right there, Vishal. That's perfect. Go up.
Okay, go up, sure.
We're in the
Hang on,
sheet.
hang on.
Okay, let me push the sheet back. Okay,
One sec.
good.
So,
Go up.
so Ajit, you're not trying to create like a big lumen for the stents. So all you need is a small channel for the stents to go in, and then you go to post your
I
stents,
think
right?
it's more, yeah,
Exactly.
it's more safer to do that.
Exactly. This is only just so they track without issue, and we don't run into
3,
any issues with
4.
having
6.
not being able to put the stents in
Okay,
position.
down.
But you don't
So
need to
that's-
create a
Yeah.
large lumen. And in fact, creating a large lumen may
Okay,
be not the best thing to do in this
Deleterious
All right,
scenario
walk,
for you.
walk
because
them out. Don't detach.
you
So
want
one
the
of the
stents to
things.
stay in place until we're able to post dilate them to the
Okay.
appropriate
Okay,
size.
DSA. So one of the things I want to tell everybody is don't detach the balloons. If you have to
on
occlude
the
quickly,
wire.
ready? DSA?
Yes, it is.
So what we're going to do is
Walk
we're
it
going
all
to
the way
inject
out.
DSA, and
Keep it on the
we're not going to detach the balloon just to make sure that we have flow. And we still don't have flow. Okay, we're getting some sort of flow.
Yeah.
All right, give me the 80XLs.
So PK, as
And-
you said, I know cost is a concern, but when we're doing cases like this, I know Ajit and Vishal, you might concur with me, is VBXs add one advantage. The biggest advantage is if you use a bare metal stents in these kind of cases, or any kind of distal aortic cases, you have to create a good lumen before you land the stent because you don't know how much you have to post. If you put VBXs, at least you know that you can go.
Karthik, I don't think I was saying in this case cost is a concern. I'm saying in your vanilla iliacs where VBX are
vanilla
used
iliacs. Okay.
left and
Got
right,
it.
I think that's not right.
That's absolutely,
I did say that this case
Agreed.
is a perfect case for a VBX. Can we please get the stents?
Yeah.
Yeah, I think another reason to
is
use a
that?
covered stent is it's a
but what one?
this is a
It-
TAS-CED lesion, so
both of them
that's
same?
where the data shows that the covered stents can really make a difference in terms of long-term patency.
859 both? Yeah.
Like going over the COBEST trial, and then the other reason is if we're worried about any sort of acute thrombus or soft plaque or whatnot, then a
before
covered
we
stent
do
will help
anything, give me a
prevent
little digest.
embolization and kind of
Give me a little dinosaur.
having the
So
thrombus
Ajit,
or plaque go
I'm
through
going to do
the bare
something
metal
here,
stent.
which I think we should do is inject from the sheath. The reason is I want to see why we're not getting flow. Did we not open the distal common iliac? Let's see.
Mm-hmm.
I think we did. Oh,
We just.
I think we did, but let's
Yeah,
just see.
pretty much like a prep balloon.
So we have flow here.
Yeah.
Now I'm going to take the sheath off. Give me a little more dye, Ray.
It might be the proximal segment where
Okay, right there.
we're getting held up on.
Yeah, right where the entry into the aorta is,
Yeah.
you might not have dilated it enough.
If it's flushing off valve so fast.
Yeah, I think that's where the recoil is.
I think it's all about the
Okay,
recoil.
okay, let's go.
Right
into
where
the
your
VBX.
reentry
the other
point
one.
is. So,
So I don't think we need to go that far into the aorta, do you? I mean, let me take the. You do what you have to do. Let me take the pigtail down again.
Yeah.
And show me above, Ray. There you go.
But-
Okay, good.
but PK, you have to
That's
go
more
to the
burning.
point where the wire crosses, right? Each other, right?
Yeah, exactly.
Right, that's
what
where
I was
we're
thinking.
going. That's where we're going. Real?
So
Yeah, I mean,
that's why it looks when you see they cross over pretty much at the distal end of the aorta. So probably
Yeah.
we didn't enter as high up as we thought we did.
Yeah.
So that's one of those markers like PK was talking about. He's
Okay,
concerned
next.
about being on the lateral side, but probably that's
The
a
other side?
parallax. But usually if the wires are crossing way at the distal
Yeah,
level.
I mean, I don't think we have to
decent
be 1 or 2 centimeters above the occlusion, but
Yeah.
we, just definitely have to be like right above it at least.
I mean, in this
But-
case, the inferior mesenteric artery was actually the cutoff where where the aortic occlusion or the disease in the aorta started. So this might be a good landmark for
Yeah, but Sardar, remember, it all depends how you entered. So if you entered more proximal, unfortunately, you still have to go from lumen to lumen.
Yeah.
So then you might have to cover. If you think you crossed,
Yeah.
entered
But I think
more
it,
proximal to the.
as Ajit was initially saying, right? You want to go at least 1 centimeter up.
Yeah.
So I think
Okay.
where the wires are
Let's
crossing
take a
might not
picture
be a
from
bad
above.
idea.
Well, let's take a picture from above. I want to just demonstrate one thing, which is that the aorta is distal to where the wires cross. See?
Oh yeah, that's.
See?
Right,
That's what I'm saying. You guys.
Yeah,
see,
this is
I think
good.
we should come back.
I don't know, PK. I think 1 centimeter into the aorta is probably a
It's
good
better
idea.
to extend it down rather than.
Yeah.
A little back.
Yeah. I think
Yeah.
this is, to me, I think we got to come a little bit back, guys.
Yeah.
I mean, this is ridiculous. Let's come a little bit
Not
back.
much, but a little bit. Yeah.
Like right there. Little
Yeah,
more?
I think that's good. That's good.
A little more,
That's,
Vishal, on your
that's
end?
exactly 1 centimeter above.
I guess, yeah, the other thing to consider is these may
Hold on,
foreshorten once we post
Yeah,
dilate
exactly.
them. So that's.
Oh, okay. Then let's
That's
go
the
up.
scary
Let's go
part.
there. Let's go there. I like that.
It's
Let's
better
go
to
to
be
the-
Yeah, that's a
overlap
good
because
spot.
it's going to shorten when we start.
Yeah,
from.
I kind of like that.
Pull the pigtail back a little
Of
bit.
course. Yeah.
How much do you think they're going to shrink?
Let me give you a little bit more.
I think they're going to foreshorten about a couple of millimeters, at least 3 to 4
Yeah,
millimeters, right?
This is
Yeah.
good.
So actually, I
Hold
think
on.
looking at the package, they actually can foreshorten like by almost a centimeter or so if we go all the way up to 16. So maybe we do need to start them a little
Yeah.
higher.
At
than,
15?
Yeah, I think so.
Okay.
It's better to extend the limb rather than not able to.
Yeah.
Well,
Extended
yeah, you
run.
want to seal the aorta for sure. Okay, I like
That's a
that.
good spot.
How's that?
I like that
All
spot.
right, ready? Who's got one?
I have the right one.
All right, guys. So what's nominal, Damien?
So you want to go together?
11.
Arjit, or you go
Right,
one by
let's
one?
go. Nominal.
Okay, you
Matter
want to
one by
keep
one or
you want to keep
together?
like
do it at the
tension on
same
those both stents so
Yeah, I
that
wanna
they
keep
don't
control.
slip down or anything.
Absolutely.
Yeah.
Absolutely.
You have control?
Okay.
So exactly, Karthik. Just for the record, if it slips, you know who's holding.
Yeah,
I-
PK is
I-
holding it.
Karthik, I want
Are
you
you
to know
gonna-
that Vishal is currently pulling right now.
2.
Okay.
Four.
He's actually pulling. I'm holding it
4.
like I'm using every ounce of muscle I
5.
have.
Six.
That's a good spot. I like it. Nice.
But Sardar, next time you need to be here and Vishal needs to be there. He's abusing me.
6.
He's abusing me right now.
Sardar, see?
8.
So we're going to have to use a
Six,
different
still
program,
6.
Still 6. Yep.
I like this idea.
8.
right? Go with the 12.
Yeah, I'm going slowly. 7. Close. Okay.
It's 8?
8.
Okay.
8 from my side.
8.
8. Save that.
Yeah, hold on.
Okay, so we're going to come down now.
1, 2, 3, down.
Okay, now we're going to just come a little bit lower. So again, guys, we're going to watch the pressure. I'm going to pull these sheets back
Hold on.
slightly. And I'm just going to balloon this segment here. And one of the things you want to watch for is the pressure drop. You know, the pressure is at 170 in the cuff, and Shreya and Vishal are going to walk it back a little bit, and we're going to balloon the proximal segment right there. Let's go up there, Vishal. That's good. Shreya, a little bit more.
Come back, yeah.
Yeah, right there. Let's go up, Shreya.
All right. So I have 4,
4.
5. It feels good. I'm at 5. I think that's
I'm at 4.
6,
6.
8,
That's good.
I
6.
think it's
I like that.
an 8.
8, down.
8.
1, 2, 3.
Okay, let's walk these out. Don't detach the balloons. So I'm fixing the
Hold on,
sheets. Double negative, yep. So this is interesting, and I think this is a great thing, Ajit, that we showed how we made decisions going as we went forward, and we're changing our plan. Even though we had a good plan, a robust plan, we're changing.
Right.
And now we are pulling this back.
It's on the wire.
Yep.
Okay. I'm going to keep it on the wire.
Yeah, I mean, I think
Yep.
it shows the
Good.
importance that you need to have more than one plan because with these
Yeah.
vascular
Ready, guys?
cases,
Yeah.
there's multiple,
DSA?
you know,
Okay.
hiccups
Yeah.
and issues that can come up whether you
Good.
plan, you know, well or not. So I think in this case we made the right call.
Yep, there you go. So now you can see the mismatch distally, right?
Yeah.
You can see the mismatch distally. So now we have to balloon the, I think the aorta, we can do an IBIS, looks pretty one-to-one to me
The
there.
right side.
But the right side is
the
severely
stem.
mismatched on the distal.
Yeah,
need
but
to
you can
extend the
just
right side,
PK, you can just put a regular bare metal stents there, right?
Yeah. Like
No, I think we'll use VBX here. I want to get a pure seal.
Okay.
So let's go ahead, guys. Let's give me another 80,
29.
8029 VBX on the right side.
And on the left side?
On the left side, we look
Pretty much the same,
actually-
right?
No,
8029.
look-
Take
yeah,
the
looks like
8029.
Let's
it.
take another picture.
Let's
You
we'll
guys
take a
see
picture from the
hypogastrics?
sheets.
Yeah,
Give me
we
a
have to
sheet.
see the
Give me a
hypogastrics, guys.
sheetogram, guys.
Yeah. Hand injection.
Hypogastrics are lower, I think, here.
Yeah, that's what I want to check too. You want to go AP or like
Okay.
the,
No,
this
just
way?
do a sheetogram here. to
Because I
decide.
think on the right side you can avoid the hypogastrics. I think the left side the occlusion starts right at the
No, you
level of the
gotta go lower.
hypogastrics.
You
Yeah.
got to go lower. See? You got to go lower. So we need more than a 29. See how I see the dissection?
Yeah.
So we just do each one individually. So let's give me the no, not a. I need a longer one.
Yeah.
I don't think 29 is going to work. You have 39 guys.
Because it's also going to foreshorten a lot.
Yep.
Foreshorten. So more contra. I think we'll go with the left first. Do individually like this.
Yeah,
10 cc.
Yeah, I need 10 cc's. This is the 80 sheet.
1 second.
One for now.
Yeah, but most likely.
Well, don't open yet.
Don't open.
So now we're gonna, Ajit, we'll go ahead and take a picture, and then we'll do the left, and then we'll do the right.
Mm-hmm.
This is also an Excel, right, Mike?
Is that an? Are these XLs?
Oh yeah.
So roadmap that.
XLs?
Yeah. Hold on.
What?
No. It has to be reference. Hold on 1 second. If you don't move, give me 1 second.
You can end it right at the hypogastric.
Yeah, exactly.
And then we got to post dilate it.
Yep.
Yeah.
Okay.
All right, give me the 8039.
I mean,
All right,
in this case,
8039.
Preservation of the hypogastric is important
Yeah.
because he's a
Yeah.
young
patient.
male person.
Yeah.
8039.
Profit.
So Ajit,
What do you? Yeah.
a question from the audience is: when the foreshortening happens for the VBX, it happens both on the proximal and distal end, or?
Yes, 10.
Yes.
Yeah.
Answer is yes.
Yeah, the answer is yeah. Especially where you're ballooning, of course, because that's the area that's going to lose the length.
Well, the beauty is it depends on whether you're trying to post dilate the entire VBX or the beauty of this stent is you can dilate one part of it and not the other part of it, so you can actually tailor it to match different anatomy. 1 second's
Yeah, and I
almost
think the
done.
teaching point is you really have to land your stent, where you think it's going to end up after you post dilate it, not where you want it to be, which
Right.
is what we did here.
Right there is good for me.
1 second.
You like that?
Yeah, I like it.
That's
Because
very
it's going to
good.
foreshorten and we're going
It's
to
going to
leave the
foreshorten. I think that's
hypogastric.
good.
Exactly.
Perfect.
You can even pull back a dot, PK.
Okay.
I think it's
Right
fine.
there.
I think it's
There you go.
It's pretty okay. Yeah, that's
Pull
good.
back. I did pull back a
Yeah,
dot,
that's
so
good.
this
That's
should be
good. I saw it. That's good.
11 is nominal.
All right. Right?
It's interesting.
Should I go up?
Yep.
All right, going up.
So, go.
Yeah, the weight popped. That is true.
Perfect.
6, 8,
10, 11.
10, and 11.
Okay. Down. Now we got to post dilate. Off roadmap. Go up again. I'm going to just push it up a little bit. Hold on.
Push it
Yep.
up a
Let me
little
pull the
bit.
wire.
Yeah.
Hold on.
Exactly.
Okay, let me hold the wire.
Thank you, sir.
1 second.
There you go. Okay. Go to 15.
What do you think about the proximal segment? I think it looked pretty good, actually.
It did.
think
Yeah, it
very
looked pretty good. Yep. I think it's a
12.
good seal.
12 is
Yeah.
I mean, we still have to post it a little bit, but I think we got a good seal.
Well, the only question is whether we should go with two 11-0 balloons and just match the aorta, right? We only went
Yeah,
with
yeah.
these are 8-0,
Agreed.
16,
Yeah.
or maybe
Agreed.
10-0, be conservative. Walk this out, guys.
fluorophore.
Give me a 10-0
Make it 10
balloon
or
now.
10. Make it
Yeah, I
20,
think
20.
10 was
No,
good.
I'm just going to do the distal first. Give me a 10-0, 20 balloon now.
You want to finish the right side also, PK? Or?
No,
Yeah,
let's do
let's
it one
finish
side at a time, and then we'll kiss above.
You're taking a picture to see where it is, how it is?
Yeah, I'm just going to do a nice see where we have to post dilate to oppose the distal iliac.
And so, like we were,
Where's the die?
like we were
Sorry, where's the die?
mentioning before, one of the other advantages of the VBX is you can manipulate the
I think I
stent
gave
size
one
like
thing
this. So,
failing.
if we had used a bare metal, we wouldn't have had that
Sorry,
option.
Liz.
But now we can kind of post dilate it to match the distal extent, which I think is another very valuable benefit of the VBX.
Mm-hmm.
Yep, 10-0-20.
Very nice.
Nice.
Yeah, the distal edge needs to be sealed. So
Yeah.
it's fine. I think 10 will take care of that. So.
Okay. Good. Oh, we are all the way up.
Nope, walking back. Sorry.
6.
A little more.
Right
A little more. Right there.
Okay.
Yeah, it's a good
It's
spot.
good.
It's a good spot.
Shoulders out.
Yeah, yeah. It's going to be like a 1 millimeter shoulder out.
2,
If this extended into the external iliac artery, what would you use distally?
3.
Use the
I would probably just use a
self-expanded.
bare metal stents. Yeah,
Yeah.
say
6.
self-expanding bare metal. I would probably use
7.
like a 12 or
7.
10 bare
Okay.
metal.
Okay, give me a little diagram.
Do you use VBXs in the
Put me
external
on
iliac
non-
artery?
And,
We do,
Get rid of that
it
now,
depending
please.
on the calcification,
cap?
but we usually tend more to use, Viban, of course, self-expanding stents. But if you
Gotta go
have
up
to
a
use a
little more.
covered stent,
Walk it back.
Viban. Otherwise, we usually use a bare metal
Walk it
stents,
A little bit.
Right.
self-expanding
You know,
bare
now?
metals.
Yeah, I completely agree.
I think we need
would
we
probably
need
just use a bare metal.
a 12.
inside the stent.
If I do need a covered stent,
1202
though, I
balloon,
just
guys?
traditionally, because Vibons have been around
Yeah.
longer,
2,
Yeah,
I would use.
and also it's
Don't
more
go up
flexible,
anymore.
and I think
Right.
4.
That being said,
4 is
we
good. Down.
started using VBXs for, renal and visceral stents
Sorry, Liz.
and
Go up
during
now.
our fenestrated aortic cases, and
Yeah.
where they take these, pretty significant bends.
Yeah.
So far, they've done very well.
Get us
So
a 12-0
I think
balloon now.
VBX is a very flexible stent. And probably would do okay in the external
2.
as well.
5,
5.
6,
6.
8.
8.
Down. All right, there's still a mismatch, and I think part of it is that we need to go with a little. See, so we need to go with we need to go with 12. 1202.
so.
So this is kind of
s-
tailoring the
Yeah.
stent to the
So,
vessel.
so Ajit, the question. So, would you be okay with that mismatch right at the level of the bifurcation, Ajit, or PK, Vishal?
I think I'll be fine with it.
I mean, I
but-
think it's ideal to try to size it 1-to-1 to the vessel. That
Right.
being said, if we couldn't do it, I think we've created, at least a 8-10 millimeter lumen. So
Right.
probably in the shorter term, that would be fine.
I mean,
but I think we're trying to-
It's a high flow state. It's a high flow vessel, so I get it. But I mean, I think it's like these stents are meant to be tailored, so let's tailor it,
Yeah,
right? I mean, you can take the stent up to a 16 if you need to.
right. Because
As long as you don't come out of the stent in this balloon angioplasty, you're going to be fine.
Okay.
And that's the idea. So that's why I'm puffing out as Vishal goes up. I'm just going to give a little dye to make sure the balloon doesn't come out. Right?
he's on the younger side, so I
Okay.
think the more durability we can
Yeah.
create here
Okay.
and the bigger lumen, the better it will be in the long term.
6.
I think probably go in a little bit, PK, you think?
Get down.
Yeah.
There's a lot of shoulder on the balloon, so
Yeah. Now go up.
yeah,
That's much
that's
better
probably
already.
better.
It's already expanded. The distal end looks much better expanded. I guess
I like that.
4, 5,
6.
6.
Okay, down.
1 second off.
Yeah, down.
Off floor. Yeah.
That's
Give me a
good.
little dye, Ray.
Don't mind. Okay.
So, so Ajit, looking at this, right? If the external iliac is
Walk it
so
up.
big, I'm assuming the common iliac is pretty much larger or the same size.
Mm-hmm.
So if that's the case, if you're creating so much of amount of expansion in the distal part of the stent, would you do the
That
same thing
looks
on the
great.
front?
You see
That
that?
looks very good. Yeah.
That looks great.
Yeah. Now we're done
Would you
here.
do the same thing for the
Let's
proximal
do
and the
other
mid
side.
part of the
Watch this
stent?
back.
Opening it up.
Yeah.
Yeah, we,
I don't think I don't think you have to, because the other thing that I'm considering in
You wanted the
my
839 again?
Let's
mine
take a
is
picture.
Take a picture,
technically
yeah.
right. We have 2 kissing iliac extents in there.
Thanks, yeah.
We don't
Right.
truly have, we're not sure if we're fully sealed proximally. So the last thing I want to do is disrupt the iliac and overinflate a large balloon in
Right.
the common iliac origin and disrupt it.
8.
So I think
8.
sealing the end is okay,
8-0.
but I wouldn't be so
No,
aggressive
you just
about
need a
doing
short
it
stent.
close
29
to the
should be
aorta.
fine.
29,
That's
8029, guys.
Right,
I don't think there's an
fine.
82. Yeah.
Agreed.
8029, and I need another 12-0 balloon. Yep. So I think here we're
Okay.
going to stent it, and then we're going to be, and then we'll go ahead and kiss out the proximal and do a final IBIS. So I think, I think it's just we have to
This
kiss the
10.
proximal with 10 O's. I don't know,
10,
it's up to
10.
you.
Yeah, I agreed.
I mean,
Agreed.
to get a proximal seal.
Yeah.
Yeah, I think 10 O's would
Where's
be,
the stent?
would be fine.
This is 10.
I need the
we need
stent,
the stent.
BBX.
I probably want to go much higher than that, you know, but I think a little bit would be good.
Agreed.
You only have 39? You don't have 29?
But to kind of elaborate on that question, if I was doing an aneurysm repair, I would definitely, you know, and I had seal proximally with like a aortic stent graft,
7
then I would
8
definitely,
29
you know,
is
feel
better.
more comfortable being aggressive with
I
the
can only go
limbs.
to
If,
11.
you know, they had a occlusive disease in their iliac arteries, that I would make sure,
But 39
you know,
is too
iron
big.
out
Give me
with
a
a large
29.
balloon.
So we're going to go to
then I
8
have seal
29 and
proximal
probably.
and distally, you know,
What
I'm
happens
sure
if you
about.
go past 11?
So that's what I was asking.
What happens if you
Ajit,
go
like,
past
because this is
11?
not an aneurysmal disease, I was asking like how much would
8
you
or 29?
actually push yourself
29.
to give a good seal distally? Because it's not aneurysmal disease where, you know, you're going to have a leak or something. So
But
No, but you know what? I think you also got to think about it this way. This is not a seal. This is a dissection here. You can see a flow limiting dissection, not a flow, non-flow limiting dissection. You can have an itis for clot, and plus this is a young man who has vascular disease. He may have coronary disease.
Right.
And our coronary colleagues, when they go up with the wires, generally don't fluoro. And what happens is what will happen is that you may get under this stent. You know, a lot of times the patients have procedures in outside hospitals. Come in, you push the J wire up, and you get under a stent strut.
Yeah, we see
and it's
it all
normal.
the time.
It happens. I mean, it's nothing. You know, being disparaging. I just think it happens. So I definitely think that it's better to get you know, a perfect result while we're here. Everything okay, buddy?
No, he's just moving. That's fine.
Huh?
It's okay. Let it go. No.
No, I think he's pretty good right now. No, he's pretty good. We're almost done. I know this case has gone on a little longer, but I think. I mean, if you think about it, we're doing a distal aortic reconstruction. All this yapping from Vishal, and now it's we're only at 9:30. Vishal, any comments?
No comments. All is well that ends well. That's what
Sardar, any comments?
Yeah.
No,
Sardar and me are like the quiet ones.
We all love Vishal.
And you have to understand, Shreya's presentation was like an encyclopedia of vascular disease. It was awesome.
She was here till 2 in the morning.
I know. It was awesome. I'm being honest. I mean, I'm not being sarcastic. It was awesome. It was an awesome presentation.
She's already been cyanized, so it's okay.
She's already been, she's already numb. Okay, we don't have, do you have a 7029? Give me a 7029 and we'll take it to a 11 or 12.
11 is fine. I think that's okay.
Yeah, so I mean, Ajit, you know, when you...
What is it?
Shreya, did you talk about axillobifem?
No,
really,
we have
right?
an 8029.
I don't remember you mentioning it.
Just, I mean, briefly,
fast
I
and
know
one
Dr.
side.
Rao
So
talked about
can
it.
you talk about, as a surgeon, because I think for cardiologists, we need to understand some of the bypass options. Obviously, aortobifem, everybody gets it.
Yeah.
Shreya mentioned the axillobifem. You know, we talked about the femfem. When do you choose an axillobifem?
Yeah, no, that's a great question. So to start, you know, there's 3 bypass options for aorto-iliac occlusive disease. Aortobifem, which is, you know, the most durable and the best one, but also the most invasive. Femfem, if you only have one iliac, you know, segment that's occluded or diseased, and then an axillobifem. So axillobifemoral bypasses, I typically reserve for patients with CLI, you know, that have rest pain or tissue loss. And the reason being is it's probably one of the least, it's less durable, and the patency rates are not as good, depending on which literature you follow. But in general, the patency rates are not as good as, certainly not as an aortobifem, and even for a femfem. So if you're doing it for claudication, and the patient has a, you know, decent, you know, or longer life expectancy, it's probably not the best operation to do for claudication for that reason. So I typically reserve that for patients that have, you know, rest pain or tissue loss.
I think you can pull back a little bit, PK. Yeah. So Ajit, you think aortobifem is much less morbid surgery than sorry, axillobifem is much less morbid procedure than aortobifem, you think?
Yes, definitely.
Yes.
You have to go
so, you know, if I were doing this for someone that had acute aortic occlusion and acute limb ischemia, if in a, you know, lower risk procedure, lower risk patient, we would consider aortobifem, and a higher risk we would do an axillobifemoral bypass for that very reason.
And the durability of axillobifem is better than or same as aortobifem?
Walk it out, bro.
Aortobifemoral bypass is the best patency we have. Axillobifemoral is definitely have a much lower patency rate.
Okay.
You know, like for aorta bifurcation, we're talking about 90+%, you know, at 5 years.
12?
So it's not the same for an axillary femoral.
So, and what about anticoagulation in both VBX as well as other surgical procedures? Do you treat these in surveillance, Ajit?
Yeah. So for iliac stents, I typically just put them on aspirin. I think it's a large vessel. It's a large, you know, we're talking about vessels that are over 8 millimeters, and I think one antiplatelets is enough. If I'm putting the VBX elsewhere, like in the SFA or POP, like in a smaller vessel, I might consider, you know, putting them on Plavix as well. You know, that I would do for like 1 month. In terms of surveillance, I would see him. I would get an ultrasound or a CAT scan, depending on whether you have a good vascular lab, in about 1 month. And if that looks good, I would see him again in, you know, about 3 to 6 months, and kind of go from there. I think.
What's nominal?
You know, for
6.
if depending on how high you go into the aorta, and
6.
Go to 8.
again how good your vascular lab is, that depends whether you need a CAT scan or not.
Down.
I don't think it's unreasonable to get at least one postoperative CTA to kind of see how things look.
Maybe take a shot.
What are your kind of algorithms for these patients post-op?
Yeah, that's what I do. I mean, for this patient, I don't know. I mean, yeah, I would probably get a CT for this patient because we think we were in a dissection plane and everything. Because if I think I'm in a true lumen, unless I put an aortic cuff, I don't go for a CAT scan as a follow-up. I just go based on ultrasound and velocities. Especially we had the monophasic velocities and everything, so I think I'll be fine with
I
it.
think it's 1-to-1.
Yeah, it's 1-to-1.
Looks great.
What do you think, Ajit?
Looks great.
Well, we can take a picture from the top as well.
Yeah, a little bit less than 1-to-1. Right?
But you're taking the tenos anyways to the top, no? On the way out, do it, no, PK?
No, we
I
just.
think-
No, it looks pretty good.
It looks pretty good.
Yep. All right. Now give me 2 tenos to the top.
Okay, hold the sheet.
10-0-40s.
We have 1 10 here. 10.
So this hopefully will be our final shot, and then we'll do a final intravascular ultrasound, and then we'll be done.
This is actually a nice demonstration how flexible we were during this entire intervention. We went in with a certain plan, and we actually during the case we readapted, and now we ended with a kissing stenting.
Well, I also think the beauty is it's an hour and a half, and we're in the final step, God willing.
Final step.
And I think that it shows that we can do these complex cases in a multidisciplinary manner with good feedback from both operators. I think this is really the future of our field for us to work in this manner. It could easily be done by either or, but the point is there's not enough surgeons and not enough interventional cardiologists to treat these patients alone. So it has to be a team-based approach. I mean, these patients are out there, they need therapy, and the truth of the matter is, the more of us that can do this very well, the more of us can actually treat the population. It's sort of like, I don't want to get anything political, but it's sort of like stroke, it's sort of like other areas as well. And I think, vascular surgery, and I see at least at Sinai, has really shown how we can work well together and really make a difference in taking care of patients.
Yeah.
Because I'll be honest with you, this patient, I would have, and Karthik and Vishal would have just gone with bilateral kissing stents, and that turned out to be what we did. But the aortic cuff is something that I didn't think about, and you bringing that up, I think was a phenomenal idea, and obviously for the audience to know when to use it, what to use it, and why not to use it, like we did here, right?
Mm-hmm. Yeah, no, I think it's great that we can have this multidisciplinary kind of discussion about the patient, because there's so many different ways of doing things. We're trained in slightly different ways, so having that discussion really enhances all the options we have, and I think it's best for the patient too, to really decide on what's going to be the best approach and best treatment for the patient.
Right, so I'm just fixing this. I'm going to give a little bit of shoulder lag, as they call it, and we're just going to go up. Let's go to just 1 above nominal, guys. Let's go to 7.
Let's go together. All right, fine.
This is taking the 8-0 to a 10-0. And we know the aorta is an 18, right? So
still 2.
2.
Yeah, still 2. Barely 2. Okay, 3.
4.
Maybe 4 is all you need, huh?
4.
Yeah.
I think 4 is all you need there.
Barely. Yeah, 4 now.
It looks pretty good.
Okay, still 1.
What do you think, Ajit?
I think that's good.
Yeah, I like that. I think we got the seal up top. Okay, and distally, we'll expand it down.
160.
Okay, let's walk it back. We'll take a shot from above.
Give me a second. It's gonna go. I show the short balloon. Okay. Keep it on the wire.
Okay, let's do a quick DSA from above, guys.
Yeah.
We can keep the balloons attached.
Yeah, on the wire. Yeah, it's on the wire.
Ready?
DSA.
Okay, ready?
Let me whenever you are.
Well, actually, let me go AP.
Yeah. 1 mag out.
Yeah.
Okay.
Okay, good.
So to put the catheter down.
You see the contralateral aorta on the other side? See what's
There's
the
a
aorta on the left side? There's a gutter.
Yeah, there's a lot of gutter. I think we might have to do more.
Yeah, post dilate it higher up.
So you want to go with 212s?
Yeah.
Yeah.
212 is 24, right?
Definitely.
Yep.
Yeah.
Don't you think?
Yeah,
Right,
I think we have to.
And you should hang it in the aorta a little bit now.
Yeah.
Agreed?
hopefully- Yeah, I think we should do
212s, guys?
and hopefully it doesn't foreshorten too much.
212 balloons. 12. We have it? Okay.
Ajit, you think we could have gone up a little bit more?
I mean, it's really hard to estimate, because you don't know how much it's going to foreshorten. We definitely pushed it higher than
We were
Yeah.
at
normal.
15.
Yeah.
Yeah.
And it's still at
still
15.
actually at
It's still
15.
at 15, so I think we're okay.
Sorry.
1240s. 20s would be better. 1220s, Chief. All right, good. 40s even better. The bigger, the better. So again, for our folks watching at home, we're approaching 1 hour and 40 minutes, but I think that this is very important here to understand. Ajit, can you talk about the consequence of this lack of seal on the opposite side?
Yeah. So I think,
Okay.
this could negatively impact the
Okay.
flow dynamics in the aorta, and potentially down the road it can lead to thrombus, and you could have issues with, the iliac stent kind of thrombosing off or getting, recurrent disease.
And this is what the cuff would have potentially avoided, right?
Yeah.
I think we made the right decision because definitely with the
I'm
cuff,
gonna clean.
we were in a different situation. Can you put me on coronary, guys? So I'm going to see properly.
Okay.
And shutter in for me, Vishal bhai. And mag up. I'm going to be right there. Good. Excellent.
Okay. You have the other one?
Yes.
Yeah, sure.
We're just doing a final balloon, sir. We'll be done in a second.
PK, would you go the same pressures on both sides or probably more on the right?
It's a good question.
Probably just do the right first, then left, and then do a kiss.
I think Vishal's idea I like a lot. Do the right first, then the left, and then kiss. But I don't want to crush, so I want to go at least nominal on the left.
Yeah, on the left so that it
yeah.
can prevent the crushing to happen.
Exactly. So you
Just
can't
go like 4
yeah.
or something and then go higher
I
on
think
the right.
four. I think 4 is pretty much it.
Yeah.
So let's go to 4 on both guys. Let's just
on.
kiss.
I think the most
Yeah,
important
Yeah,
thing,
then go
though.
slowly up and
Yeah.
kiss. That's fine. That's fair.
What's
and
that?
then go
What's
a
that,
little
Ajit?
bit.
I said I think the most important thing is that we have them inflated and deflated at the end at the same time, so that way, because these are balloon expandable, so they're not going
So
to
let's
expand
go
on
up
their
at
own.
the same time.
Yeah.
So probably
Alright, bear with
go
us.
go 4-4
two.
and then go higher on the
Right.
right. And then finally kiss with the same
Still
pressures.
2,
2,
3,
3,
and
4.
4,
Yeah, I wouldn't go
Go
much
to
higher
5 on the right.
5.
Okay.
than-
Leave it up. Can you give me some dye from above?
I think
That
still
looks
there is
pretty
a
well
That's
lot.
pretty good
close.
there. Okay, down together.
1, 2, 3. It's going to ease out right now.
Yeah, we're going to take a DSA picture right here. DSA, guys.
1 second.
Walk back.
I think the pressures are fine, right, PK?
Okay.
Yeah, brushes are beautiful. I'm just leaving the balloons up, so in case I need to go up again.
Yeah, yeah.
One picture here and then one picture without the balloon.
No, we're done. You see that?
Yeah.
Beautiful.
Now,
Now we're
I
done.
think that's great. Yeah.
Now we're done. Okay, good. Let's walk it out.
hold the sheet.
That's very good.
Let's get a quick IBIS, guys.
Or then I should have kept the bullet. One of them.
No, it's okay.
We have an
Do you
overlay.
routinely use IBIS for your iliac stents, or
I just do it here just to see the. I mean, at this stage, I think just a proximal, or you think just there's no reason.
Well,
No, I think IBIS is a great idea.
Okay, so give us a 014 wire and an exchange catheter.
Because here it's, like you said, proximally it's hard to see.
Who's that, Chu?
You know, if the stents are fully expanded. And especially since they're crisscrossing, you want to make sure there's no compression or kinks.
Correct.
So IBIS is a great way of identifying that.
Word tip or any kind. Oh, there it is. Thanks.
No, hang up. Can I have a Spartacore?
And you can confirm that if they're fully opposed to the aortic wall.
We got it.
Yeah.
Yeah, I'm just going to do IBIS of the prox.
Okay.
It's going to be hard to tell because they're covered stents, but we'll manage.
At least we'll know the distal transition, you know, the proximal transition. If it's nice, then I think it's okay.
Right.
Mm-hmm.
So you would do IBIS from both stent sizes, right, PK? Both stent sides?
I think at this stage, probably I think we might be able to see both. I'm praying we do, you know. And if we are, that's great. Wire. And IBIS, thank you. So we're going to do a quick IBIS. Damien, I know the monitor is not good, but this monitor is really good, Damien. This one is really good. So play it over here. Yep, that's perfect. So we couldn't see the other monitor, but now we can see this monitor. So now we're going to play this IBIS live for you, Karthik, and we'll call it a day. Yep. So here we are. And right now the aorta. We can look up there, Ajit. That's better.
Yeah.
So that's the aorta. Record, Damien.
Start recording, Damien.
So we're going to just slowly come back now.
That's the other.
Oh, yeah.
So this is the transition. Aorta, stent. Aorta, stent. Damien, stop it. Let's do chromoflow now. So what I really want to see is there how much is there flow behind the stent, right? So let me go aorta here. Chromoflow within the aorta. You can see the lumen there. Now I'm coming back. And there's my stent. There's a very little flow behind the stent.
Especially on the 9 o'clock.
Yeah. And now you don't see anything. Yep. Okay. So I think we're done, guys.
Yeah.
I think we're done. I'm just going to change. I'm just going to go ahead, do a final DSA run of the entire iliac system. And then is my heart rate low or what's the story? Okay. Okay. So we are going to go ahead and do a final run, Karthik.
Non-DSA.
I'm going to pull the sheets back a little bit.
Iliac first, just to make sure.
One iliac shot of DSA.
I'm going on corner.
And then just maybe shudder it a little bit.
We're going to keep it at DSA right now.
Right. Okay, this is DSA.
Yeah.
Can we just show the image? You guys can take the IBIS off.
IBIS off, guys.
Let's go back to, Let's switch to back to the cine images.
Okay, ready?
Okay.
Nice.
I think very important to stay on long delayed cine. Make sure you don't have any microperforations, which we definitely didn't. There's no venous phase here, so you can clearly tell here that the proximal aorta is well opposed. And, you know, that's bowel gas at the proximal is very important to see it before you inject and see it after. And you can see that that filling defect is bowel gas in the aorta. And I think at this stage, I mean, the only thing I would probably do is just you know, monitor him, like you said, with ultrasounds and see how he does. So that's it. As far as groin management now, would you be comfortable with we're closing?
I think we can per close both sides.
Per close would be good.
Yeah, we're going to do either per close or 8 French angioseals or whatever the team wants. And we're going to take it from there.
All right.
So, again, thanks, everyone. And I think it was a great case, hour and 50 minutes to do a very complex aortic reconstruction in a combined manner. So, again, Karthik, can you close up? And a happy holidays and a happy new year, everyone.
Thank you.
PK. Thanks, Vishal. Ajit.
Nice
Thank
job.
you, Shreya. Great job, guys. Ray, great job.
Great job, Shreya.
Lizzie, Ramon.
Great. Lizzie, I'm sorry.
All right, guys. So I think it was a very exciting case. Don't you think? All right,
Totally agree.
fantastic case, done very safely and cleanly. That's what. Sometimes these cases take a little more amount of time than expected because the plans change. But I think we got a great result, and we look forward to seeing you again in the January 27th for our new first case of the 2021. Hopefully, the next year is going to be fantastic for everybody all over the world who's watching us. We wish you a very, very good Christmas and New Year's and happy holidays. And hopefully 2021 brings a fresh and peaceful and a happy life for everybody. And we look forward to seeing you there. And this case will be archived at the later of the day into the website. So we are ready to answer a lot of questions I'm sure you have. Me and Sardar, thank you so much for having you guys.
Thank you very much. Happy holidays.